Good morning, respected sir, esteemed dignitaries, faculty members, and and colleagues. Today, I, Dr. Lavanya Taneja, first-year resident from the Department of Traumatology and Surgery, would like to take the opportunity to present a combined clinical round with in collaboration. The topic: bull gore injury to neck in an adult male, with collaboration with departments of radiology, anesthesiology, and critical care medicine. Firstly, I would like to invite Dr. Avnish Katiyar sir to give brief department introduction.
Good morning, Kapoor sir. Good morning, Malhotra sir. Good morning, Medical Director Jaswal sir and senior faculty members, colleague and my dear resident. So before we start with the case presentation, I will like to give a brief introduction about the department. The post-graduation in the Department of Traumatology and Surgery started in 2022 and one resident per year. And all over India, we have three medical colleges. Mahatma Gandhi is one of them. Two batches passed till May 2025. We have only four doctors in the department, one faculty, that's me, and three residents of one first year, second year, and third year. We have two alumni. Dr. Sunil is pursuing MCH in trauma surgery and critical care from AIIMS Rishikesh. Dr. Rushal is selected in the same course. We have facilities for the trauma care, the point of care, the resuscitation room in the emergency department, and point of care laboratories like blood gas analysis, portable ultrasound, and portable X-ray machine. These are the academics we follow in the department, and we have around 25 to 15 OPDs per day, and total admission around 9, including follow elective and emergency admissions. And we have operated last year 225 cases, and that includes the few. We are presenting glimpse of the few surgeries. We have performed the total gastrectomy for a total gastric necrosis in age of 25-year male patient, and we have done a laparotomy for the case of retroperitoneal abscess for perforated appendix in 83-year female, and this is the case of presented with the case of intestinal obstruction. But as the case of cecal bolus and malrotation of gut, we perform the stoma. And this is the case of the abdominal trauma, impalement injury to the gut, in the abdomen, and evisceration of gut. And this is the case. This is the case of our student intern met with the road traffic accident, had evisceration of gut from the left thorax with the diaphragmatic injury. We performed successful surgery and patient recovered. And this is the case of 60-year male patient with the massive right side flail chest with massive hemothorax. We perform the surgical stabilization of the ribs, and the patient discharged well. And this is the case of flail chest with indrawing of the ribs into the lung. So we reduced the thoracic wall and restore the thoracic wall and fix the ribs. This is the case of open thorax. The patient has road traffic accident in the left side, and right side patient has bull horn injury into thorax. We did thoracic wall repair. And this is the case of physical assault with the knife, and we did chest wall repair. This is the case of gunshot injury to the thoracic cavity. We performed right interlateral thoracotomy with tractotomy of the wound. And this is the case of projectile free projectile bolt. We performed, patient was doing cutting the stones, and the bolt is detached from the machine and entered into right thorax, and the patient sustained hilar injury of the lung. We did inferior lobectomy, and the patient discharged well. This is the same case, the same machine, another patient with the different trajectory. Entry wound the same, but in the right side, but trajectory is going down. So patient having right side lung injury with diaphragm injury, but liver. So foreign body was found inside the liver. So we performed the laparotomy and removed the bolt, and patient is still admitted. Post of patient develops bile leak, but successfully reduced. This is the case of limb injuries. If the patient is in deglobing injury, we perform the reconstruction surgeries. Second case of machine cut injury, we did amputation. The road traffic accident with mangled limb, we perform the damage control surgery and amputation. We perform the vascular trauma, the post-traumatic popliteal artery injury. We did post-appendicular and interposition graft repair. Patient discharged well. We do hand surgeries that includes tendon and vascular repair. The patient tendon repair was done and doing good, the good functional outcome. We also do the cut throats that includes trachea and neck injuries. These are the glimpse of the case we performed last year. We have total 6 publications in last 4 years, and we have done this one CME on thoracic trauma in 2025. We used to celebrate for road safety awareness and conduct trauma prevention campaigns in 17th October on occasion of World Trauma Day every year. And we also do a social outreach program for prevention of workplace injury like bolt injury, hand cut injury, drill bit injury around the industry in Mahatma Gandhi Hospital. And we conducted a mock drill in hospital for mass casualty incidents and prevention of the trauma and management in hospital patients. We participated in the conference for students. We teach how to intubate, how to suture, and how to put Riles tube. And in last year we participated in national grand rounds from the Indian Society of Trauma and Acute Care. The same case we have presented the flying bolt in the thorax. And I received a grant from the IPR department, Government of India, for rib fixation system, and we also received the certificate of excellence from the Mahatma Gandhi Hospital. Now I would like to call Dr. Lavanya Taneja to continue for the case presentation. Thank you.
Very good, Avnish, very good. So all these cases operated by your team? Good. But then who looks after them in the post-operative period, because you are only 4 people? Because you have to be there in the emergency plus all these patients in the ward.
Sir, we get support from the Department of General Surgery
and
Department of Critical Care team. So in the post-operative, sir, yesterday in the night we operated grade 4 liver injury. Very serious patient, but critical care in the night. The critical care team will take care of the patient.
Yeah.
We follow the patient.
Any faculty from general surgery? Yeah. So I was going to request that since they are very short of hands, it would be very nice that I would even request that if possible you could post your residents by rotation in with them. Yes, because they are doing good work. We are getting good cases, but then in the interest of patients, because they are short of hands, it would be very good that the general surgery department lend support. Thank you. Thank you.
Thank you, sir.
And some of these days we don't celebrate, we observe.
Thank you, sir. We begin with the case under the guidance of Dr. Avnish Katiyar, sir. Our patient, a 45-year-old male, brought to us in the emergency room by his brother after alleged history of attack by a bull. The patient had a penetrating injury to the neck. The incidents occurred in Bharatpur on 7th December 2025 around 6 p.m. Patient was brought to us on 8th December 2025 at 12:20 a.m. following a 6-hour delay after taking primary treatment at a private hospital in Bharatpur. Upon arrival at our hospital, the patient handover was given in MIST format. MIST stands for Mechanism, Injuries, Signs and Symptoms, and Treatment. MIST is a standardized systematic way to manage handover from pre-hospital personnel to the in-hospital team. The handover indicated that it was a high-speed motor vehicle collision with the bull. Injuries noted were a penetrating neck wound with active air leak noted from the wound site, which raised suspicion of possible airway injury. Patient's airway was noticed to be compromised due to air leak present from the wound. There was no bleeding from the neck wound. Patient was conscious, oriented, slightly tachypneic, and saturation on arrival was 87% at room air. Patient's airway was assessed, oxygen support given, saturation maintained at 5 liters of oxygen via nasal prongs. The adequate fluids, antibiotics, analgesics were given and wound was dressed. Then patient was received an emergency on 8th December 2025 as mentioned before and was assessed as per ATLS protocol, in which primary survey was done, which includes X, A, B, C, D, E. X stands for exsanguinating hemorrhage, A for airway and cervical spine restriction, B for breathing and ventilation, C for circulation and control of hemorrhage, D for disability, that is neurological examination, E for exposure, that is prevention of hypothermia. In primary survey, we start with X, which stands for exsanguinating hemorrhage. No active bleed was noted from the wound. Dressing applied over the wound site. Then following the hemorrhage control, airway and cervical spine restriction examination was undertaken. The airway was compromised. Oxygen was supplemented at 5 liters per minute with saturation maintained at 100%. The patient had a GCS of 15/15 and local examination revealed a 2 into 5 centimeter defect over the anterior neck corresponding to the bullhorn injury site. Following airway assessment and cervical spine stabilization, breathing and ventilation assessment were performed. Chest rise was reduced with subcutaneous crepitus present. Bilateral subcutaneous emphysema extending from neck to upper chest was present. Bilateral air entry was reduced, which necessitated placement of bilateral intercostal drainage tube. Moving on to the circulation examination. Patient was stable with a pulse of 92 beats per minute and blood pressure of 140/74 millimeters of mercury without any inotropic support. Fast examination was done and was found to be negative. 2 large bore IV accesses were established. Blood samples were drawn and initial fluid resuscitation was with 1 liter of 1 ringal lactate. Moving on to the disability examination, the patient was neurologically intact with GCS of 15/15. Pupils were equal and reacted bilaterally. No focal neurological deficit was noticed. Then coming to the exposure, that is prevention of hypothermia. Hypothermia was prevented with blankets and warm fluids. Then along with primary survey, adjuncts were used such as multipara monitors for vital monitoring, fast examination for assessment of free fluid and abdominal cavity, ECG for heart monitoring, chest X-rays for lung status, and Ryle's tube inserted for gastric decompression. Urinary catheterization was done and ABG analysis were done. In chest X-ray, bilateral pneumothorax and bilateral surgical emphysema were seen. Later, after completion of primary survey, reassessment of primary survey was done on 8th December 2025 at 12:40 am after stabilization of the patient. Then coming on the secondary survey. Secondary survey is a head-to-toe examination considering of head, neck and face, chest, abdomen, pelvis, spine, upper extremities, lower extremities, skin and soft tissue examination.
In this particular case, as has already been pointed out, neck is not a part of secondary survey. It is
Part
one of the initial evaluation. Sometimes the sequence has to change depending on the site of injury.
But the secondary survey is done to rule out other injuries that cannot be ruled out on the primary survey or that are missed. So on head examination, no signs of head injury was present or any external wound was present. On neck, injury was present as mentioned before. Chest rise was normal after insertion. Chest rise was normal after insertion of bilateral ICD tube and crepitus was present but reduced, and bilateral airway air entry was normal. On secondary survey, abdomen examination, no external injuries were seen and bowel sounds were heard. On pelvis, spinal, extremity and soft tissue examination, there was no evidence of any external injuries noted. Then ample history was taken. Patient had no known allergies, no significant past medical history, and patient is not on any long-term medication. As per history, the patient initially received primary management at Bharatpur, Rajasthan. Last oral intake was approximately 2 hours prior to the injury, and the event leading to the injury, as mentioned before, was collision with the bull. Later, patient was reassessed following completion of primary and secondary survey. Airway was patent with oxygen support, breathing adequate and hemodynamically stable. The patient was planned for urgent radiological evaluation for CCT neck and thorax for assessment of associated aerodigestive, vascular, thoracic and intrathoracic injuries. Now I would like Dr. Mansi Shokeen from Department of Radiodiagnosis to discuss about radiological findings in this case.
Thank you, Dr. Lavanya. Good morning, respected dignitaries, faculty members, and my fellow colleagues. I am Dr. Mansi Shokeen, second-year resident from Department of Radiodiagnosis, and I will be taking this case further. As requested by the Department of Trauma Surgery, chest X-ray and CECT neck were conducted. So this is a chest radiograph, PA view, showing multiple fibrocalcific lesions which are seen in bilateral upper lobes. These were likely sequelae of any old infective etiology. Also here we can see the lucent areas in the bilateral apical lobes with absent bronchovascular markings. So these findings were suggestive of bilateral pneumothorax. The one on the right is chest radiograph, AP view, post ICD insertion. Here we can see ICD tube shadows bilaterally. Yes, sir.
Just point out where is the pneumothorax in first X-ray?
Sir, it's not very clear in this image, but in the apical lobe, lucencies were appreciated with absent bronchovascular markings.
Pneumothorax. When you take the X-ray in a full inspection, then when it is a minimal pneumothorax, you can visualize only the lining and which you can visualize it. Of course, you may are not very much sure, but even then you can see on the top. So that was the thing. And further it is confirmed by the other modalities.
I think on the right side you can see the pneumothorax, not a very big one, but you can see. You can see the lung border inside the chest wall, on the right side at least.
Sir, I think on the right side there is deep sulcus sign present, suggestive of pneumothorax, and some sort of pneumomediastinum is also there. You can see the continuous cardiac sign. There is air below the heart, and on the left cardiac border there is also some lucencies there. So it is pneumomediastinum along with pneumothorax is there.
Yes, sir.
On the left side, go back please. On the left side, you can see that longitudinal curved air just parallel to the aortic arch and the heart.
Yes.
That is pneumomediastinum.
These are the axial and sagittal CECT images in the mediastinal window. Here we can see there's a defect which is seen along the tracheal wall. I'll use the pointer. So here we can see the defect along the wall of the anterior wall of the trachea in the anterior and anterolateral aspect. At the level of D2, D3 vertebral level, free air is also seen in the mediastinum. So these findings were suggestive of tracheal injury. These are the axial and sagittal sections. Here we can see the focal outpouching in anterior and anterolateral aspect of the trachea. These are the axial and sagittal CECT neck sections showing a defect in the posterior wall of trachea at D2 level. And this defect was seen extending up to the level of D4, D5 vertebral body, and the length of the involved trachea was approximately 4.3 centimeters. These are the images of the axial CECT image in the lung window. Here, bilateral pneumothorax was appreciated. Also, there is free air pockets which is seen around the great vessels and the heart. So, the findings were suggestive of bilateral pneumothorax and pneumomediastinum. This is a normal 3D rendered image of a normal trachea. Here we can see the trachea. This is the right main bronchus, the left main bronchus. And I have also put a 3D model showing tracheal injury with focal outpouchings anteriorly as well as posteriorly. Summarizing the CT findings, the findings were suggestive of tracheal injury, bilateral pneumothorax and pneumomediastinum. Now I request Dr. Lavanya to take the case further. Thank you.
Thank you, Dr. Mansi. Now, the routine investigation, continuing with the case, routine blood investigations were done, which were essentially normal. The platelets were slightly decreased and blood urea levels were slightly increased. Then the final diagnosis, it is a penetrating neck trauma with zone 1 injury, then tracheal injury, that is grading 4, and bilateral pneumothorax with pneumomediastinum. Further, the plan of management included pre-operative optimization, definitive tracheal repair, post-operative care, rehabilitation and regular follow-up. Following ER stabilization, patient was shifted to ICU on 8th December 2025 at 100 hours in hemodynamically stable condition with bilateral ICD showing air leak and adequate column movements, where continued resuscitation, oxygen support and pre-anesthetic optimization were carried on prior to emergency surgical intervention. Now I would like to invite Dr. Ananya Chaturvedi from Department of Anaesthesiology for further discussion of their management.
Thank you, Dr. Lavanya. Good morning, esteemed dignitaries, respected faculty members and colleagues. I am Dr. Ananya Chaturvedi, second year resident from the Department of Anaesthesiology, and I would continue with the anesthetic management of this case. We are repeatedly taught that in a difficult airway emergency, such as cannot intubate, cannot oxygenate, the front of the neck access in the forms of cricothyroidotomy or tracheostomy are the final life-saving steps. But what happens when the front of the neck access itself becomes an emergency? When the very pathway we rely upon for rescue is bleeding, torn and disrupted. We received a requisition for an emergency bedside pre-anesthetic checkup from the Department of Trauma in view of penetrating neck injury for surgical exploration and tracheal repair. On primary examination, the patient had a neck trauma. The pulse rate was 82 beats per minute. Blood pressure was maintaining at 142 by 72 millimeters of mercury on no inotropic support. Respiratory rate was 22 per minute. And oxygen saturation was 100% on 5 liters of oxygen. Despite suffering penetrating neck trauma with tracheal injury, the patient was conscious, oriented, and maintaining oxygenation. Preoperative evaluation, history was reconfirmed. Airway examination showed adequate mouth opening, Malampatti grade 2, and a sternomental distance of 14 centimeter. More importantly, patient showed no signs of severe airway obstruction such as stridor, altered sensorium, or respiratory distress. The external injury measured 2 by 5 centimeter. There was no cervical spine injury present. Bilateral air entry was initially reduced, but after bilateral ICD placement, it was normal. Bilateral intercostal drain showed air column moving. Preoperative evaluation was further done. Blood investigations and ABG were within normal limit. Chest imaging and CT findings reconfirmed the tracheal injury and pneumomediastinum. 1 unit of packed red blood cells was reserved. nil by mouth status was adequate, informed high risk consent was obtained. This patient was accepted under ASA grade 5E. This case posed multiple anesthetic concerns. The foremost challenge was to maintain oxygenation and preserve spontaneous ventilation while securing the airway before the induction of anesthesia. The rationale for using awake fiber optic intubation was it maintains spontaneous ventilation, real-time visualization of the internal extent of the tracheal injury, and a controlled placement of the endotracheal tube distal to the site of injury. Guiding the fibroscope, however, was done carefully so as to prevent dislodgement of the fibroscope. Secondly, high airway pressures could convert a partial transection into a complete one. Positive pressure ventilation had to be avoided because they can worsen the air leak despite the ICD present. A double setup for the emergency tracheostomy was kept ready with surgeons scrubbed for immediate intervention in case of airway loss. Conventional blind tracheal intubation is particularly dangerous in this case because it can create a false passage, tube misplacement, and again complete tracheal transection. Furthermore, there is a risk of hemodynamic instability and aspiration. Additionally, a bull-Gore injury to the trachea could have associated injuries to the thorax, esophagus, and vasculature. Patient can land up in post-operative airway edema, anastomotic dehiscence, and infection. Intraoperative management. The plan of anesthesia was awake fiber optic nasal intubation followed by general anesthesia. In the operating room, standard ASA monitors were attached, 2 large bore IV cannulas were present, an arterial line was secured for invasive BP monitoring, and oxygen was administered through nasal prongs at 4 liters per minute. Injection glycopyrrolate IV was given as an anti-sialagogue. Injection fentanyl and injection lignocaine 2% IV were given to blunt the stress response to intubation. Adequate airway topicalization was performed with various local anesthesia techniques with a maximum dose of 9 mg per kg. Nebulization using 3 ml of 4% lignocaine. Oropharyngeal aerosol spray with 10% lignocaine. Bilateral superior laryngeal nerve block with 2 ml 2% lignocaine. Transtracheal block via the cricothyroid membrane with 3 ml of 4% lignocaine, and spray as you go technique with 2% lignocaine while passing the fibro-optic scope. Continuing, a flexometallic endotracheal tube of 7.5 millimeter internal diameter was used, and it was fixed at 28 centimeter under visualization distal to the tracheal injury. After the confirmation of ET tube placement with bilateral air entry equal and end-tidal carbon dioxide, in general anesthesia was induced using propofol, and muscle relaxation was given using rocuronium. The depth of anesthesia was maintained using sevoflurane and oxygen-air mixture of 70:30. Throughout the procedure, the neck positioning was carefully maintained to avoid tension at the injured site. Ventilatory settings involved lung protective strategies such as low tidal volume, zero positive end expiratory pressure to avoid high airway pressures. Injection paracetamol and dexamethasone were given to provide multimodal analgesia and reduce airway edema. Once the tracheal repair was completed, an elective post-surgical tracheostomy was performed 1.5 cm distal to the injury. A cuff tracheostomy tube was inserted while the endotracheal tube was simultaneously withdrawn under the continuous monitoring of oxygen and end-tidal CO2. The patient remained hemodynamically stable throughout the procedure. Now I would like to invite Dr. Hemant to continue with the case.
Thank you, Dr. Ananya. Good morning, respected chairperson, sir, esteemed dignitaries, faculty members and colleagues. Myself, Dr. Hemant Sharma, PG third year. So, I would like to explain here surgical management of tracheal injury repair. General anesthesia as explained by Dr. Ananya. The patient was positioned supine and slight neck extension, and the procedure was performed under general anesthesia to ensure optimal airway control and safe surgical exposure. Operative steps. Under general anesthesia, emergency neck exploration was performed through the traumatic anterior cervical wound, revealing 5 into 2 centimeter defect with intact major vascular and aerodigestive structures. However, a near complete 90% tracheal transection with air leak was identified. The airway was secured, followed by thorough debridement and irrigation. Primary tracheal repair with 40 PDS interrupted sutures and the protective tracheostomy placed distal to the repair site. Hemostasis was achieved and the wound was closed in layers, with drain placement ensured definitive airway control and stable postoperative outcome. And operative findings were 5 into 2 centimeter defect on anterior part of neck at the site of bullhorn injury, no injury to common carotid artery, IGV, ECA, esophagus and thyroid gland. 90% tracheal transection were found. Post-operative care, patient shifted to SICU post-procedure in an intubated, sedated and paralyzed state for the ventilator and hemodynamic support, and continuous monitoring of pulse, blood pressure, oxygen saturation, urine output, ABG parameters and bilateral chest drain output was maintained. Mechanical ventilation with adequate analgesia and sedation was continued along with the broad spectrum intravenous antibiotics, pain management and supportive intensive care. Now I would like to invite Dr. Ankur Sharma from critical care.
Doctor, before you go.
Yes.
CT showed a very large defect on the posterior wall of trachea, which is the membranous part.
Yes.
How was that handled?
Sir, actually the CT finding was different. When we opened the trachea, there is a defect present only on anterior part. Posterior band was intact. So only cartilageous part was there, but in the CT scan outpoaching was there, but there is posterior wall is intact.
So did we review the CT in view of the operative findings?
See that. See, actually, sir, like you said, the posterior part is membranous, so we could see a focal outpouching, and there was subtle irregularity. So we definitely suspected that there is an injury of the trachea, anterior aspect as well as posterior aspect.
Can you tell us, was there any tracheal loss?
Yes, there is a
only one tracheal ring was fractured, so we debride that tracheal ring.
So what was the level of tracheal loss? What ring?
So, fifth tracheal ring.
Fifth tracheal ring. And what was the site of tracheostomy?
Tracheostomy is 2 ring below, because it's at the level of below. Proximal. Yes, around. Because the defect was
if you go on the 7th tracheal ring, then the tracheostomy will invariably go into one of the bronchus. 7th tracheal ring. So basically, in a tracheal repair, if we do a tracheal repair, primary tracheal repair, the tracheal repair has to be stented, either in the form of keeping endotracheal tube for 48 to 72 hours, or putting a stent, which is a Montgomery stent. If you leave, the body's nature is the wound which you want to heal, they will open up, and the wounds which you don't want to keep it patent, they will fibrose. The trachea also behaves in the same way. If you don't stent the area which has been repaired, it's ultimately going to get fibrosed. So that has to be stented either by the tracheostomy, by doing a higher tracheostomy, or doing a Montgomery stent, or keeping the patient intubated for 48 to 72 hours.
So patient is stayed intubated.
No, the tracheostomy tube is below the site of repair.
Yes, sir.
The trachea behaves in a way where you want the airway to be patent, it will fibrose. You want the abdominal wound to close, it will open up. So, should have been probably done at a level above the...
See, tracheostomy below the wound is for ventilation. Tracheostomy above the wound is for stenting.
Even when we put tracheostomy above the level of repair, we have to make sure that the cuff of the tracheostomy should not be at the level of the repair. Because if you keep the cuff inflated with a nasogastric tube in situ, you may end up losing this repair and also developing a fistula.
Thank you, sir.
Thank you, Dr. Hemant. Today good morning everyone. Today I, Dr. Ankur Sharma, DM resident critical care medicine, I am going to discuss about the ICU management of a case of tracheal repair. We received a 45-year-old male, operated case of tracheal repair, with tracheostomy and bilateral ICDs in situ. The patient was received sedated and paralyzed with stable hemodynamics, maintaining a saturation of 100% on vein circuit. On auscultation, the air entry was equal bilaterally and there were no active air leaks in the ICDs. The neck was kept in a flexion position and was maintained throughout that way because of the preservation of the anastomotic repair. This management was shown in subsequent stages as well. The patient was rolled from the stretcher to the bed via log rolling maneuvers, in which 4 people, one at the head end stabilizing the spine, one at the shoulder level, one at the abdomen level, and one at the lower limb level, stabilizes the patient and moves the patient en bloc from the stretcher to the bed en bloc. The patient was immediately connected to ventilator on controlled ventilation with a mode of volume control ventilation on FiO2 of 60%. Concurrently, fentanyl infusion for sedation and analgesia and atracurium infusion for paralysis was started to prevent ventilator dysynchrony of the patient. The patient was kept nil by mouth and Ringer's lactate on maintenance dose was started. On day 2, we reduced the FiO2 from 60% to 35% and atracurium infusion was stopped, although the sedation was continued for analgesia and to prevent coughing and reckless neck movements. Strict posture maintenance was continued. Neck support with pillows was also maintained. On day 3, the sedation was also stopped and the spontaneous awakening trial was initiated. In spontaneous awakening trial, we see the neurological assessment of the patient if he is able to maintain spontaneous breaths without signs of agitation or any fighting. The patient, on successful initiation of spontaneous awakening trial, was put on spontaneous breathing trial with minimum support of CPAP-PS ventilation. The patient tolerated the spontaneous breathing trial and hence was put on the minimum setting of the ventilation. Enteral nutrition via nasogastric tube was started. On the day 4, we successfully transitioned the patient off the ventilator and was put on TPs for oxygen supplementation. On day 5, the patient was comfortable on TPs and rehabilitation with gentle chest PTs, assisted range of movement exercises was started. High calorie diet, high protein diet was initiated for immediate recovery of the patient. On the day 6, the respiratory status was improved significantly and therefore the patient was weaned entirely to the room air. Gentle chest and rim physiotherapy was also encouraged. Day 7, the patient was physiologically stable and was able to do routine activities by himself and therefore after multidisciplinary consultation was shifted to ward. So the 5 pillars of post-operative management were based on the priorities of preserving the airway, protecting the repair and promoting the recovery. In the airway management, we went for early extubation/weaning off, depending upon the feasibility as by the spontaneous awakening and spontaneous breathing trials. We gave humidified oxygen by HME filters. We maintained adequate IV hydration, and we also did gentle suctioning only if required, as indicated by increased peak pressures or audible crepitations of the patient in the chest. We preserved the anastomotic position by keeping the neck in slight flexion and neutral position by putting pillows under the neck. We avoided hyperextension and minimized tension across the suture line. Earlier by analgesia and sedation and then by patient counseling. We controlled the mobilization early by passive range of movement exercises and then by assisted range of movement exercises. The tracheostomy site and the tracheostomy site was thoroughly assessed and cuff pressures were documented in each shift by a manometer and overinflation was prevented. The tracheostomy was secured by straps and putting 1 finger breadth distance so as to prevent strangulation of the patient. Sterile dressings were put in the tracheostomy site, and we watched for granulation tissue, and we also look for any pus or discharges from the tracheostomy site. We gradually advanced the diet, first in the quantity and then in the nutritional value itself. Adequate hydration was maintained, and early ambulation and physiotherapy was encouraged in these patients. Surveillance for airway compromise, bleeding and infection and subcutaneous emphysema were done. Daily X-rays and chest palpitations were done to assess for the subcutaneous emphysema. Irrelevant and exaggerated activity was restricted throughout the stay in the ICU. Now I would like to call Dr. Hemant for further management of the patient.
Thank you, Dr. Ankur. Now, recovery and rehabilitation. Patient demonstrated progressive respiratory and hemodynamic recovery in SICU with satisfactory lung expansion, successful pulmonary rehabilitation, maintained neurological stability, GCS 15/15, and plan for ward transfer followed by discharge with follow-up and rehabilitation advice. Discharge and patient during post-operative period was vitally stable, extubated, and post-operative day 2. Chest drain was removed on day 3. Later was the collection reduced on the day 5. The left ICD was removed, followed by right ICD removal on day 9. While alongside RT feed was started on day 3 with 50 ml per 2 hour, which gradually was increased, and on day 9 RT was removed and liquid feed started on day 10. Gastrographin study was done, following which the patient was started on oral feed by day 11. On discharge, patient was hemodynamically stable with full lung expansion and tolerating oral feeds. Patient and attender were counseled for the warning signs, and follow-up was done after 7 days in trauma surgery OPD. On POD 15, suture was removed. And review literature. Articles on cut throat bullhorn, Gore horn injury or to neck rear, how may case, and articles published. So these are the zones. Zone 1 starts from clavicle to cricoid cartilage, and zone 2 from cricoid cartilage to angle of mandible, and zone 3 is angle of mandible to base of skull. Now, neck trauma zones, structures and management. Neck injuries are classically described in 3 anatomical zones, where zone 1 and zone 3 are more challenging due to limited surgical access and often require advanced imaging and endovascular approaches, while zone 2 is the most accessible and commonly explored. However, modern trauma can increasingly follows a no zone or hard sign based approach, where management is guided by the clinical status rather than the anatomy, prioritizing early airway control, hemorrhage management, and timely surgical or endovascular intervention to improve outcomes. Now, AAST tracheal injury grading and general treatment. Grade 1 contusion and minor mucosal injuries to grade 5 complete transaction or massive tissue loss, with management ranging from conservative observation in stable low-grade injuries to primary surgical repair in most full thickness laceration and complex airway reconstruction and resection, and with anastomosis in severe high-grade injuries, emphasizing the treatment decisions are guided by injury severity and airway stability. Now, neck trauma, how to approach neck trauma. This is algorithm. If you suspect a neck trauma, does wound penetrate platysma? If no, do local wound care. If wound penetrate platysma, if yes, go through a ATLS primary survey X ABCD hemorrhage control. Then we go with hemodynamical stability. If patient is unstable, immediate operation, surgical exploration is recommended. If patient is stable, then assess hard sign. If hard sign is present, then immediate surgery is indicated. If no hard sign, evaluate to a soft sign. Soft sign present, then do neck CT, angio, endoscopy plus minus bronchoscopy. If you found injuries, yes, then operate endovascular. If no injuries were found, observe 24 hourly. If soft signs are absent, do CT, angio, neck and selective. If no injury, then observation and discharge the patient. Now, Gore injuries represent deceptively severe high-energy penetrating trauma where external wounds often underestimate significant internal damage. Literature consistently shows that although abdominal injuries predominate, cervical involvement, though rare, can be life-threatening, particularly when airway structures are involved. Early ATLS-based resuscitation, prompt airway control, accurate imaging, and timely surgical intervention remain the cornerstone of the management, with outcomes strongly depend on early recognition and the high index of suspicion. Now, surgical management of bullhorn injury, Gajvi et al. Study done in India was Gajvi in 2016. A 12-year review of 67 bullhorn injuries demonstrated a clear male predominance, with abdominal injuries accounting for more than half of all cases. Head and neck involvement was exceptionally rare, occurring in only 1.5% of patients, highlighting the unusual nature of our case. Notably, nearly half of the patients with abdominal trauma and peritoneal breach with bowel or rumental prolapse, underscoring the significant penetrating force associated with bullhorn injuries. This case emphasizes that bullhorn injuries, although often appearing deceptively minor externally, can cause deep and extensive internal damage, including rare but life-threatening cervical and tracheal injuries. It reinforces that the need for a high index of suspicion, early airway control, and timely surgical exploration to prevent significant morbidity and mortality. Now, key findings. This case highlighted the shift from zone-based approach to the modern no-zone strategy, where clinical findings guided management. The presence of heart sign, particular airway compromise, and surgical emphysema was highly predictive of significant tracheal injury and necessitates urgent intervention. Ultimately, prompt recognition and decisive surgical management were key of achieving favorable outcomes. This is patient video. Patient video about thanking.
मथुरा गोवर्धन का रहने वाला हूँ। मेरा 7 दिसंबर को एक सांड के साथ एक्सीडेंट हुआ था, रात को करीब शाम 7:30 बजे करीब, और मेरी सांस की नली डैमेज हो गई थी। इसके उपरांत मैं रात को ही सीधा महात्मा गांधी हॉस्पिटल आया था। यहाँ आने के बाद इमरजेंसी में मेरे को देखा गया, देख के मेरे सांस की नली डैमेज मिली थी बुरी तरीके से। तो यहाँ के डॉक्टर साहब, डॉक्टर मंगतानी साहब और डॉक्टर अवनीश कटियार सर ने और उनकी टीम ने तुरंत ऑपरेशन किया और बहुत अच्छे से मतलब ट्रीटमेंट किया। मैं इनका सभी का बहुत धन्यवाद करना चाहता हूँ। अभी मैं पूरी तरीके से बिल्कुल फिट हूँ और महात्मा गांधी की पूरी टीम को मतलब हॉस्पिटल के लिए मैं बहुत बहुत धन्यवाद।
Now, learning points. This case highlights that penetrating neck trauma is a true surgical emergency where rapid assessment, early airway and hemorrhage control, and timely definitive repair are critical to survival. It also reinforced the importance of multidisciplinary approach and the trauma principles that time is tissue. So, special thanks for management of MGUMST, CCR Review Committee, Department of Radiodiagnosis, Department of Anesthesia, Critical Care Medicine, patient and his relatives, supporting staff, technicians on duty. Thank you.